Greetings, I'm Dr. Deborah Fennell, and it's my pleasure to welcome you to the International Nurses Society on Addictions webinar series that focuses on the use of opioid therapies for treatment of opioid dependence and on the safe use of opioids in the treatment of chronic pain. This series is one of the many resources made available by the Prescribers Clinical Support System Opioid Therapies, a program that's funded by the Federal Center for Substance Abuse Treatment and operated collaboratively by 6 other partner organizations: the American Academy of Addiction Psychiatry, the American Psychiatric Association, the American Medical Association, American Osteopathic Academy of Addiction Medicine, American Dental Association, and American Society for Pain Management Nursing. Just a few quick housekeeping notes before we get to the presentation today. In the upper right side of your computer screen, you'll see a control panel. In the lower portion of that panel, participants can type a question or comment and submit it to the webinar organizers. You can do this at any time during the presentation. We will reserve about 10 minutes at the end of the presentation for questions and answers. And if we are unable to get to all your questions in the allotted time, our presenters have agreed to respond to them in writing, and those will be posted on the website in the future. Today it's my pleasure to introduce Dr. Margaret Dykman and Sabrina Morelli. They will address transforming nursing through evidence, nurses, and methadone maintenance therapy. They will provide an overview of the RNAO International Affairs and Best Practice Guidelines Center to develop an understanding of the Methadone Maintenance Treatment Best Practice Guideline, purpose, scope, and background. They will briefly discuss the mechanism of opiate addictions and the use of methadone as a treatment option. They will identify educational, organizational, and policy recommendations to create an environment of support for nurses. In addition, they'll identify key practice recommendations in the best practice guideline pertaining to the nurse's role in methadone maintenance treatment, and further identify key RNAO initiatives that support nurses in working with clients with addictions and mental health problems. Margaret Dykman is a nurse practitioner, PhD, honorary research fellow at the University of New Brunswick. She recently retired from her position of professor in the Faculty of Nursing at the University of New Brunswick. In addition to teaching in the nurse practitioner program, Margaret was responsible for managing the Fredericton Community Health Clinic, a clinic which was established by the Faculty of Nursing to improve access to health care for a number of special populations living in the area. For the last 20 years of her career, Margaret has worked closely with people who misuse drugs, being a primary care provider, a counselor, and an advocate. Because of her experiences, she was asked by RNAO to be the panel chair of the development panel that completed, researched, and wrote the clinical best practice guidelines for supporting clients on methadone maintenance treatment. Margaret also was a member of a research team that's been involved in a number of studies focused on the needs of persons who inject drugs and who are on methadone for improving the health of persons misusing opioids. Our second presenter is Sabrina Morelli, RN, Masters in Nursing Program Manager, International Affairs and Best Practice Guidelines, Registered Nurse Association of Ontario. Sabrina is the Addictions and Mental Health Program Manager with the Registered Nurses Association of Ontario's International Affairs and Best Practice Guidelines Center. Her experience in the healthcare system stems from working in both hospital and public healthcare systems in chronic disease prevention. Her practice is focused on social determinants of health and women's health. Sabrina has a particular interest in the influence nursing has on improving health outcomes. She's a registered nurse with a bachelor's with honors degree in health sciences, specializing in rural health from the University of Western Ontario. Sabrina also obtained her Bachelor of Science in Nursing and Master's of Nursing from the University of Toronto, specializing in community health. Her role at RNAO is to manage the multi-phases of guideline development and support the widespread implementation and uptake of the Mental Health and Addiction Initiative and best practices across Ontario. I want to give a warm welcome to Ms. Morelli, who will start the presentation, and Dr. Dyckman, who will follow.
Well, thank you very much, Deborah, for that wonderful introduction. So good afternoon, everyone. It is my pleasure and Margaret's pleasure to be here with you today to present Transforming Nursing Through Evidence, the Nurses and the Methadone Maintenance Therapy. As you can see on the slides, this is Margaret and myself, and again, it is our pleasure to be here. My name is Sabrina, and I'm the Program Manager at the Registered Nurses Association of Ontario, and I manage the Addictions and Mental Health Program. And Margaret is the Panel Chair also on our Methadone Maintenance Guideline Development Panel. To provide an overview of our session objectives, today we will provide an overview of the Registered Nurses Association of Ontario, the International Affairs and Best Practice Guideline Center, to develop an understanding of the methadone maintenance treatment best practice guidelines, purpose, scope, and background. We will briefly discuss mechanisms of opiate addiction and the use of methadone as a treatment option. And we will identify key practice recommendations, educational, organization, and policy recommendations to create an environment for support for nurses to work with methadone maintenance treatment. Finally, we'll also identify key RNAO initiatives that will support nurses and other healthcare professionals in working with clients with addictions and mental health. To provide you a brief background on RNAO, RNAO is the Professional Association of Registered Nurses in Ontario. We represent over 35,000 nurses across Ontario, as well as in Canada and internationally. We've been in existence since 1925, and we are the strong, credible voice leading the nursing profession to influence, promote, and support healthy public policy and clinical excellence. One of our key signature programs is the Best Practice Guidelines program. This program is funded by the Ontario Ministry of Health and Long-Term Care and has started in 1999 due to a commissioned report called Good Nursing, Good Health, an Investment for the 21st Century. This key report had two initiatives and recommendations that supported the lead of the development of the Best Practice Guidelines Center. And these recommendations included to design and provide supports for nurses to gain clinical expertise in clinical areas, and then to assess and evaluate these new approaches and how they impact on the client's outcomes and work environments for nurses. This led to the program's mandate development, and that is to develop, to disseminate, and to actively support the uptake of evidence-based clinical and healthy work environment nursing best practices through the use of best practice guidelines, and to evaluate their impact in clients, organization, and healthcare systems outcomes. One of the key initiatives at RNAO's International Affairs and Best Practice Guidelines Center is the Mental Health and Addiction Initiative. This, too, is funded by the Ontario Ministry of Health and Long-Term Care. And our mandate is to build capacity amongst nurses and other healthcare professionals to implement and sustain addictions and mental health best practices in nursing practice. So we've talked a lot about best practice guidelines. So what are best practice guidelines? Best practice guidelines are a set of systematically developed statements based on the best available evidence that help practitioners and clients make the best decisions about their health and their health care. This figure, every best practice guideline that you will see that comes out from the RNAO has three sets of key recommendations. The first set of key recommendations that you will see are the practice recommendations, and these articulate what does the nurse need to do in a clinical setting. The second recommendation that you will see is the education recommendation, which articulates what does the nurse need to know in the setting. And finally, organization and policy recommendations follow what are the environmental supports required for nurses to use best practices in their settings. This figure displays the elements of the process of developing, implementing, and evaluating clinical best practice guidelines. The top circle on your screen discusses the rigorous guideline development process, starting off from topic selection to the recruitment of the expert panel, to conducting the rigorous systematic review, to stakeholder review, and finally publication. All of the guidelines that RNAO publishes are reviewed on a 5-year basis. The next circle you'll see on the bottom left-hand corner talks about implementation strategies utilized to ensure best practices are integrated into clinical settings. And finally, the final circle that you'll see on the bottom right-hand side talk about strategies to evaluate and monitor best practice integration into clinical settings. To date, RNAO has 38 clinical best practice guidelines and 9 healthy work environment guidelines on a variety of different topics. Our guidelines are all translated into French, Spanish, Portuguese, Italian, Japanese, and Chinese. Our 38 clinical guidelines also include 4 foundational guidelines, such as client-centered care, establishing therapeutic relations, as well as others. On your screen, you will also see 10 mental health and addictions-related best practice guidelines. These best practice guidelines are also supported with 2 implementation toolkits that discuss how to integrate best practices into clinical nursing settings. As well as we have 3 educator guides on a variety of different topics that talk about the integration of best practices into an academic curriculum setting at the undergrad and graduate level. All of our guidelines are available for download at rnao.ca for free or for purchase at rnao.ca. As mentioned in the introduction, today's webinar will focus on the Methadone Maintenance Treatment Best Practice Guideline. This initiative started in 2007 due to a coroner's inquest due to a death related to methadone. As a result, there was a commission task force put together by the Ontario Ministry of Health and Long-Term Care, and they released a report entitled the Methadone Task Force Report. In this report, there were 11 initiatives that were mentioned that were created by the task force to be completed by 4 driving organizations in Ontario. One of these 4 organizations was the RNAO, and RNAO was selected to develop nursing best practice guidelines in relation to methadone maintenance treatment as well as addictions, and training and mentoring of nurses working with clients or potential clients on methadone. On the screen right now, you will see a list of panel of experts in the field who were recruited to help develop the methadone maintenance treatment best practice guideline. Included on this list are a variety of different experts that bring expertise on their topic area. They represent a variety of different organizations across Ontario, including the College of Nurses of Ontario, our regulatory body for nurses in Ontario, the university and academic settings, corrections, hospitals, and community clinics. We also engaged in a stakeholder review of our guidelines, which also included health professionals and nurses, clients with lived experience, and their families. All of the guideline development panel team all have experience and vested interest in methadone and provide a valuable contribution to the creation of this guideline. This guideline has been developed to synthesize the current evidence and recommend best practices based on the evidence, and to offer nurses a reliable source of information on which to make decisions concerning practice of methadone maintenance treatment. This best practice guideline is intended for nurses in all practice settings across the continuum of care, including those not experts in methadone maintenance treatment. And the key underlying assumptions are, number 1, this guideline assumes that nurses will only perform those aspects of assessment and intervention for which they have received appropriate education and have the necessary skill set. And number 2, expected that nurses will seek appropriate consultation in the instances where clients' needs surpass the need to act independently. The guideline expert panel felt it was necessary to have a theoretical framework to guide the development of this guideline, and selected a harm reduction approach and a social determinants of health approach to frame their work. These frameworks will be discussed throughout today's presentation. The research questions that are guided the development of the guideline included, number 1, what do nurses need to be aware of to do an appropriate assessment for clients who are opiate dependent and candidates for methadone maintenance treatment? Number 2, what do nurses need to know about methadone maintenance treatment? Number 3, what is the role for the nurse in methadone maintenance treatment? And number 4, How do nurses support a client who is a potential candidate for methadone maintenance treatment who present for their care? A search strategy was created and developed by the panel in consultation with a librarian and included a variety of databases and key search terms which are listed on your screen. Our guideline development process starts out with the development of the research question, purpose, and scope of the guideline, as well as the development of inclusion and exclusion criteria. We undertake a comprehensive, rigorous, systematic literature search with a health search librarian and nursing research associates. All retrieved articles are then screened for inclusion and exclusion criteria, and included articles are then quality appraised and data extracted. The data is then given to our panel of experts for creation of a guideline. Prior to publication, the finalized guideline is reviewed by a panel of stakeholders that include health professionals, including nurses, clients with lived experiences, and their families for a final review. At this stage, the guideline edits are made and the guideline is published. Also, a manuscript in a peer-reviewed journal is released about the guideline. For the methadone maintenance treatment best practice guideline, a manuscript was published in the Journal of Psychiatric and Mental Health Nursing, released in 2010. We will now go into background information, and I'll pass it over to Margaret.
Hi, everyone. For this part of the presentation, we're going to talk about some general information about addiction, some general information regarding the methadone maintenance, and some general information about harm reduction. And all these things are actually found within the guideline. So most of what we're discussing, if you download the guideline, you'll hear it all or find it all within that document. The other thing that I wanted to add to Sabrina's discussion is that the guideline was not developed to provide information for people working in methadone maintenance treatment programs. It was really put together to give all nurses a basic, a lot of information on methadone maintenance, because people were being admitted to all units, or they were being seen in community by nurses who didn't have background information. And so if you're working in addiction, you may find some of the things within the guideline a little bit basic, but that's the reason that it's basic, because it wasn't put together for specialists. It was put together for all nurses in general. Next slide. And I thought we probably should start with the mechanism of opiate addiction. I personally feel that a lot of our attitudes and what we don't know about addiction leads to some of the problems with working with people who misuse drugs on a regular basis. So how many of you have actually heard that, you know, people could stop using if they just did it? So, and that's not the way that addiction works. And unless you know the mechanism, then you might be able to talk that way, but once you know it, you have a better understanding that it won't work that way. So the slide you have in front of you gives you some kind of a basic, because we need to be able to see, most of us, as well as to be able to hear in order to understand some things. So people who have their first dose of whatever it is that they have chosen to use, whether it's for pain or whether they thought it was to be a crutch to help them through a certain confrontation, or whatever the reason that they decided to use an opiate in the first place for. And the first dose, the baseline here is where we all are. We all have a regular baseline, and everybody has a different baseline. I mean, I'm sure you all have figured out that drugs don't work the same for everybody. So personally, I can't take them there. I do not have any euphoria. I get very ill just from the drugs themselves. So I'm one of those people who could take forever and not get addicted. But other people, and many of my patients, had said, Margaret, I know if I just, the first dose I had, I knew that I was in trouble, so I knew they shouldn't give me another one. So there's a very long linear line between all of us, and we all react differently to these drugs. So the first dose, people get to feel, who then go on to become addicted, they get to feel very, very good. The euphoria is very high. It's a memorial event. They remember what it was like. But the problem is that when they come down off that first high, they don't stop at their baseline. It always dips below. And like most of us, if we feel good about something, we want to do it again. So we try it the next time. And the next time, we don't really get to feel quite that euphoric. So then we don't get the kick out of it that we got the last time. And on top of that, our baseline drops even more. So now we're way below baseline. So in order to fix that, and because we still remember, we have great memories, it's really there. And so we decide that we'll use a little more the next time, and the next time we'll get a little higher, but we may not still get to where we were with the initial dose. But again, we use more, we're going to go a low baseline. So we're going to keep dropping below baseline. And when the extra doses don't work, we're going to use a little more often. So eventually, and sometimes for some people it doesn't take very long, we're no longer using to get high here on the right side of your screen. We're using to get back to baseline. Because if we're not in baseline, we're in withdrawal. And when we're in withdrawal, we're very sick. And we don't want to be sick, and we don't want to die. And believe me, some people feel like they're going to die when they're in withdrawal. So they keep using only to get what they need to stay what they would consider well, not to get high anymore. So if you're working with people who misuse drugs on a regular basis, they'll tell you that they can't get out of bed in the morning without their fix because they can't even get their hand to their mouth, or they can't speak, or they hurt so bad that they can't move. So these kinds of things, as nurses, I think we really have to listen to, because we know that at this point people are really in trouble. Next slide. Methadone is a treatment option, and you will hear people say who don't think methadone works that it's we're putting a drug in for a drug, and therefore we're just substituting. But methadone is a long-acting synthetic opiate that binds to opiate receptors. So because it's long-acting, it doesn't have the euphoric effects that the short-acting drugs have, and it's associated with much more positive outcomes than any other treatment option that we have for opioid addiction at this present time. And usually the best outcomes occur when individuals are retained in long-term treatment. And in my experience, that treatment has always been in the outpatient setting. In Canada here, we actually use methadone as a detox treatment option too at some points, but I'm not sure, and I personally have not seen it work all that well unless it's followed up with a maintenance program. And working in a clinical situation where we used a lot of methadone, we sort of saw patients who needed to be on it for long term. Even patients who may come off of it in some point in time in their lifetime, they still need a fairly long-term treatment option in order to be able to gradually wean off of the methadone without having the severe side effects of coming off of it too quickly. And one of the things you don't want to do is bring people off of methadone too quickly, because they go back into withdrawal, they go back to craving, and once they go back to craving, then they're very much more apt to not have a successful outcome. Next slide. Methadone has been found to alleviate the withdrawal symptoms and the cravings very well, as long as you can titrate it to the right dose. And the time that there's the most dangerous interval for using methadone as a treatment option is during its beginning, when you're just beginning to start. So usually programs start slow, and they start low and they go fairly slow and titrate it up. I know in the program that I worked in, we disregarded opiate use for the first couple of months until we got people to a dose where they weren't craving, where they didn't have to go back to the street to find something else to alleviate the craving symptoms and the withdrawal. Because the methadone we were giving them didn't always do that because we weren't giving them enough. It really creates an improvement in the client's social conditions, because if you're not on methadone and you're looking for opiates constantly, your life is nothing but a kind of a treadmill where things are running very fast, because as you're injecting one dose, you're looking to wonder where you're going to get the next one. And of course, in most populations, those needing so much drug creates all kinds of illegal activities and problems for individuals and families and friends of individuals, because the need to get their drug becomes their all-encompassing life. And it provides an improvement in general health status, because it provides a steady drug that it's a known substance, it's known what's in it. Things have improved quite a lot in the last few years for people who inject drugs, because in this area anyway, in Canada, we're seeing more people injecting prescription drugs than actually injecting drugs that would come from the street and be mixed with substances that would be even more detrimental to their health. But at the same time, it eliminates that a question mark of just exactly what is in that needle or syringe, because we're no longer using that, and we're using a set dosage. Out of the 65 people that we interviewed in our methadone maintenance program after their first 6 months, all 65 stated that their health status had improved in that 6-month period, that they believed that they were in better health at that point in time. And of course, it reduces the HIV and Hep C rates because of the needle sharing. And it has, to this point in time, created a program that people stay in longer. It gets to be a problem because they have to go every day to get it in some instances. So they do get carries after a while in most programs, but the retention rate is still better in a methadone maintenance program than it is in most other addiction programs. Next slide. And Sabrina told you we were going to talk about harm reduction. And methadone maintenance is a harm reduction modality, so it fits very much under the umbrella of harm reduction. And this conceptual model that we used for the guideline was by Chung, and it can be found in a 2000 publication. And if anybody's interested, just put the question in and we'll send you the answer to what, because I don't have it in front of me at the moment, what journal it was in. But it is not only a theoretical, but it also encompasses many practical applications which people working in clinical situations really need. And it seeks to change policy in order to be integrated with current health policy, provides necessary framework for treatment of substance use in society. So it's a very broad-based framework, and I know that a lot of people working in clinical think the frameworks probably are not always handy or helpful, but sometimes when you can see things in a straight format like this, you can kind of tie all the pieces together so that one thing will lead into another. Harm reduction recognizes that substance misuse occurs and will continue to occur in society, and recognizes the diversity in human experience. And addiction problems have been around for millenniums, so there's nothing new in what we see on a day-to-day basis. It just seems to get worse when the world gets more poverty and more need and so on and so forth, but it's always been here. Not everyone has the same motivation to change or the same level of drug use or even experiences the same harms, and we've talked about that a little bit. In our population, we sort of saw 3 different levels of people who came for treatment. Those, and it's not just the external methadone that helps through the process, and there's no guarantee for people whether they're ever going to get off of methadone or whether they're going to have to make it their lifestyle forever. But we sort of broke people up into 3 groups. If they had enough internal fortitude and enough of their own internal strength, then they probably, the third of them would probably get off methadone in, say, 4 to 5 years. They could wean down. They could get stable. First, you go through the business of trying to get stable and healthy, because most people, when they come to programs, are very unhealthy. And then there's a period when they're quite comfortable with being where they are on a dose that matches what they need, and then they want more in their lifetime. And they have enough fortitude to actually move from that point downward in the methadone until they move themselves right off of it. And then you have a third of people who really don't have that kind of inner strength, so they may have to stay on methadone forever. Because I had some patients when I worked in Chicago who tried time and time and time again to start weaning off, but couldn't do it because they just would get the craving so badly that they would have to go back on, or they would go back to the street. And then you get the third who really aren't there for the treatment option. They're there for trying to get their drugs a little easier, and they're tired of working the street to get them, and they think it's an easier way to get the drugs. So they will be on as long as they stay in the program and come often enough, but they're actually the people who probably won't even stay in the methadone program. But again, looking at it from harm reduction, if they've even been off their drugs for a couple or 3 months, then that's 3 months that they haven't been on the street and getting into trouble. So every day that you can have people come clean or even be partially clean is one day better than what the day was before. Harm reduction doesn't make judgments regarding client drug use, rather seeks to provide appropriate and accessible services without barrier of stigma or negative labels. And its goal is to promote the health and safety of the individual and community through secondary prevention of disease and social consequence. The model also encourages that it is important for nurses to be aware and address their own attitudes and biases in order to provide efficient care. Next slide. So we broke the guideline into 3 different types of recommendations, as Sabrina spoke before. There were 10 practice recommendations, there were 3 educational, and there were 4 organization and policy recommendations. Because we don't have time today to talk about them all, I'm just going to talk about a few of each category. Next slide. One of them was for the practice recommendations. One of them was nurses incorporate specific skills and knowledge of addictions in their everyday practice. And these were 4 of the areas where we thought that they needed to integrate some of these specific knowledge and skills. And nurses need to know about both mental health and addiction so that they can differentiate between addiction and withdrawal issues and psychiatric symptoms. Often both conditions may be present at the same time. Educational programs should include how to complete a full addictions assessment as part of the initial intake assessment. They should also include examples of tools that can use at each stage of the treatment program to best capture all the vital information needed for the MT program to be successful. And there's a lot of these tools now, and in your different clinical situations, one of the things that your teams need to do is to look to see what the best one is that fits what you want to do with it and what you think is the most important thing that you need to be capturing for these people. Because if we don't ask the right questions, we don't get the right answers. And so, but in if we do it from a standardized position, then we're more apt to get the answers that we need in order to get the information that we want. Methadone maintenance treatment is currently the standard of care for women who have substance misuse disorders during pregnancies. Benefits of methadone during pregnancy include improved gestational age, increased birth weight, and decreased infant mortality. Now, there is always the argument that the babies may be addicted and be born with problems, but if that's weighed from a harm reduction perspective against mothers who continually shoot up and may get bacterial infections and may lose babies because they are not eating enough and are in poor situations for a multitude of reasons, then I think when you weigh the two together, it comes out on the top that putting mothers to be in methadone maintenance programs is probably benefits everybody. And then nurses working with women during their pregnancies need to know about their own belief systems and how they will influence their caring for their patients, because stigma still is a huge problem when we're dealing with people who misuse drugs. We have to sort of look at ourselves and ask the questions about how we would deal if it was us on the opposite side of the table. What would happen, and what kind of care would we hope to get, and what is it that this specific patient needs, because we really need to be offering care that's patient and client-centered. It isn't the goals, my goals that I'm trying to meet, it's the patient's goals, and what do they believe is what they need to get where they need to be as far as health is concerned. Assessment skills need to include an understanding of the signs of symptoms of withdrawal. The patient's social support system is very important, and questions need to be asked about that. And referrals need to be made where possible if the support system isn't adequate. Harm reduction principles and how to incorporate them into the plan of care. Sometimes if we've been in nursing for a long time, we don't totally understand the principles between harm reduction, and how do we get that kind of information. What physical changes and why methadone doses may have to be adjusted during pregnancy. Pregnancy can speed up the metabolism of methadone, and in our clinic with women who were pregnant, we often went to a split dose so that they had more methadone on board for the 24 hours. So different clinics use different kinds of formulas for those kinds of things, and we need to be on the top to know how to do that. How to manage women during labor with methadone, and if they've been on methadone all the way along, what do we do for pain? And what are our policies around that? Grief management for people who are unable to keep their babies. I mean, most of us, I suspect, have been in situations where mothers have been addicted, and social services have been standing in the wings to gather up any babies who have been born. So now how do we deal with the mother and the situation? How to assist patients in navigating the system. And under the ethical, legal, the Code of Ethics in Canada is structured around 7 primary values that are central to nursing practice: providing safe, compassionate, competent, and ethical care, promoting health and well-being, promoting and respecting informed decision-making. It's their decisions, it's not our decisions. Preserving dignity, maintaining privacy and confidentiality, promoting justice, being accountable. Again, all of our belief systems come in here. Next slide. So another practice recommendation was that nurses must have knowledge of the impact of the social determinants of health. And I only picked out 3 or 4 or 5 to speak to, because we all know that there are a lot more than that. But Homelessness in Canada is one of the worst ones for this group of people. And we have been going to Housing First programs, which is Canada, across Canada has been moving toward Housing First programs so that people who are addicted are not eliminated from housing. Another one that really has an impact on the addiction process and learning and where problems may occur is education, because we need to be able to teach people, and they need to be able to learn. And research has shown that addictions, a majority of persons who are addicted have low SES and education programs, and addiction then becomes a coping strategy for that and for many other things. People use drugs to cope with a lot of life situations. So the cycle really gets perpetuated. We have children who start using because they don't learn well in school, and then they can't learn because they're using, and then they get into the legal situations, and then by the time they're teenagers, you have somebody using drugs who has a learning disability, who probably has been in jail, who is no education, and who is not employable because of the whole circumstance and the catch-22 that they get into. Accessing services. One of the hardest things for people with addictions to do is to access healthcare services, because people look at them and say, oh, they're just addicts anyway. What are we going to do for them? So they don't want to access services. They don't go to ER when they just get a little bit sick. They usually go when they're very ill. So they also become a problem for the system because they wait too long because of prior treatment that they've got. And then there's support systems. Most of us think when you have a support system, it's a good system. But often, if you're a person who uses drugs, then your support system may be the specific place where you're getting those drugs. And so it may not be a healthy support system. So moving people from support systems that are unhealthy to support systems that are healthy sometimes is a problem. Next. So under the education, sorry, I lost my page. We need to be able to talk. Nurses need a formal training, but they also need training when they're nurses, because things are not static and things keep changing all the time. I've got to say that in 2014, I will have been registered as a nurse for 50 years. I can tell you back in the 60s, we didn't even talk about people who use drugs. That wasn't something that was talked about. So if you look at someone who came through an education program like I did, we need a lot of background support and continuing education programs to actually get the information that we need. But we also need to put this information into curriculums. And curriculums are kind of like the Titanic. It takes a very long time to turn them around, and sometimes they hit the iceberg. So, but we need to consciously think about what we have in our curriculums around mental health and addiction services, and then add up-to-date information so that our students, when they graduate, become competent nurses in the addiction and mental health departments. Next. Nurses incorporate addictions and knowledge and MMT into their ongoing everyday practice and into their continuing education activities. It's one thing to have them, to know the knowledge, but it's the second thing to actually use the knowledge that you have. And some of that is personal, and some of it is organizational, because if you're not helped to use the knowledge that you have, and the status quo is all that we know, then lots of times it doesn't happen, and things don't happen the way they're supposed to. So we have to add that into And to do that, we have to keep up to date. And sometimes we don't have time to do that, or we don't think we have time to do that. But we have to take the knowledge that's out there and the evidence that's available, sometimes which we found when we wrote the recommendations and when we wrote the guidelines, that a lot of the evidence base for this kind of guideline was not terribly strong. So most of it is at a level 4 rather than being at a level 1. It's level 4 evidence, and some of it's anecdotal and some of it's been garnered through experience, but it's what we have. So we need to use that, and we need to be able to move forward with it. And if you have a chance to be part of a research project, I would recommend that you all do, because it's one way to learn a lot about things. Having one foot in the clinical place and one foot in a place where they gather evidence is one of the best ways to go through nursing. And we have to look at clients as part of the process and not just as our patients. Next. We can't do this all by ourselves. Nurses can only do so much. So our healthcare organizations have to provide support for nurses. Orientation programs and professional developments regarding addictions and treatment options. Organizations are the ones that have to provide the space for us to work in. They have to be able to have the resources. They have to bring up the tools. I know in lots of organizations, all of your charting tools have to be passed through somewhere at the organizational level. And if the organization isn't on board and doesn't know, kept up to date in what's going on in the new evidence and things like that, then they're not going to be helpful in pushing through the policies. So organizations have to be part and parcel of the process. Katrina, it's all yours.
So RNAO has a variety of implementation resources to support nurses, health professionals, and organizations in implementing best practice guidelines in their setting. And some of the resources are depicted on your slide, and I'll walk you through them in this moment. The first one is the Toolkit for Implementation of Best Practice Guidelines. And this toolkit really walks you step by step on how to implement best practice guidelines and particular recommendations in your particular clinical setting. And the link for the toolkit is available on the slide. The second resource we have for support is the Addictions and Mental Health RNAO online community, which is an online network platform that allows nurses and healthcare professionals to share resources, host local events, and discuss with colleagues across Ontario, Canada, and internationally about issues and questions that they may have, or even successes that they have. We also have a 10-module e-learning series dedicated particularly on methadone maintenance treatment and addictions that can be found on the RNAO website. We also have smartphone applications available for any Android, BlackBerry, or iPhone devices that are really clinical care pathways that allow nurses and healthcare professionals at the point of contact to be able to help with the treatment of a client that is on methadone maintenance or potential clients for methadone maintenance. And these smartphone applications, the one particularly for methadone, is available in English and in French. And finally, we also have a Speaker Bureau series on our website that are online presentations that allow nurses and healthcare professionals to get further education on topics pertaining to methadone maintenance. Again, to access our guidelines, they're all available free for download on our website, as well as our accompanying resources. Otherwise, to access hard copies, they are available for purchase on our website as well at rnao.ca. And I'll pass it over to Deb. Thank you.
Thank you very much for this presentation. It was informative and very helpful. I'm going to jump in with a question of my own. And for either of you, could you just let us know how long it took to develop the guideline that you particularly focused on today?
Sure. Thanks, Deb, for the question. A brand new guideline such as the methadone guideline, from start to finish, should take about 18 months to 2 years to develop. And that's talking about that whole systematic review process that we went through, from, starting with even identifying your panel, identifying your topic, conducting the full systematic review, and then providing the data tables to the panel to be able to take that data and to create the recommendations and the supporting level of evidence, and then also to provide stakeholder input and review and then publication. So it takes about 2 years for a brand new guideline. And again, our guidelines are all reviewed every 5 years for to go back through the evidence, make sure that our guidelines are updated and are accurate.
Great, thank you.
Thank you.
Margaret, did you have anything that you want to weigh in on that?
No, it was just a very, very complex operation, I'll tell you.
Yeah. So another question that came in is, are there any advantages in treating opioid addiction with methadone over Suboxone? And not sure if you could just speak to the treatment of opioid dependence with Suboxone in Canada.
Margaret?
I was going to say, Sabrina, because you're in Ontario where they're doing it. We're not doing it here in the Atlantic at all. We're still only on methadone.
Sure. I know Suboxone is a new treatment in Canada. What I could do for that particular question, though, is if I could take it back, and I want to get you a little bit more accurate information. If the person who has asked the question, the individual, could actually just articulate a little bit more specifically what they would like to know, and I would be more than willing to get you that information to you.
Okay, great.
But it is known as a newer treatment form that is in Canada and does have quite high success rates.
And Margaret, you indicated that it's not available in your province.
Not in the Atlantic area. We're still straight methadone. I don't know of any uptake much down here, but it takes us a while to get things on the East Coast. We're a little slower, and some of our treatment options are behind some of the rest of the country where things happen. You have to remember that we don't have a lot of people on the ground in the Atlantic area. We're not highly populated, and we don't have any huge cities. We're very much a rural type of a community. So, so that it takes time.
Yes. Yes. Okay. This may be more of a comment and a question. That when you referred earlier to patients being clean, does that refer to being free from use of illicit substances?
Right.
Yeah.
Right.
Okay. All right. Another question came in, and I'm going to take some liberties, and if I don't get this accurate, then I'll ask the attendee to pop back in with some clarification. But do you insist on abstinence after induction and stabilization? And if so, for how long? And I may not have that question completely accurate, so.
I think I understand what they're getting at. Again, if you think of it from a harm reduction perspective, no. Abstinence is pretty tough. And drug use is usually not a single opiate or a single drug. In my experience anyway, most people are multi-drug users, not just opiate users. So, and programs are set up, at least here in Canada, we call it thresholds, and they can be high, medium, or low thresholds. And high thresholds means that you probably, if you use, you might get turfed. If you use something besides methadone, you might get turfed out of the program. Medium is you get, quite a few strikes and a lot of counseling and a lot of work before people decide that the option is it's not working at this point, something else needs to get done. In low threshold, there isn't a lot of control. Methadone is supplied to take care of the opiate problems, but then people are allowed pretty much to do whatever else they want to do in a low threshold program. And what happens with those are, it gives you access to the client, I think is one of the main benefits of low thresholds. In our clinic, we started out at a low threshold, and a lot of the patients themselves came to us and said that they didn't feel comfortable in a low threshold. Would we do something about it? So we bumped it into a medium. So we had a contract, we had some rules and regulations, and people were more comfortable with that. And they became their own advocates as time went on. So, but low thresholds do keep the people coming back more, and you don't lose as many from your program. And when you're talking to people on a day-to-day basis, they often move themselves toward being more compliant with whatever rules and regs there are, and use less on their own because they have the support system behind them. I hope that answers your question.
Yeah, great, thank you. And I'm not sure if this question came in from Canada or the States, but what about the shortage of methadone? How does that affect the usage of methadone for those that are using that medication?
We haven't had any problem in Canada, to my knowledge, about shortage of methadone.
And I haven't heard about that either.
Okay.
But you know what, Deborah, if you could actually just flag that question, I could do some investigation on that.
Sure. Okay, great.
To my, if we did, I would see us moving into buprenorphine or Suboxone. I mean,
and that's something we hear too. Margaret and I go around the province of Ontario to do champion workshops, and we frequently visit with a lot of nurses across the province to do addictions workshops, as well as at RNAO. We're working on a new best practice guideline called Engaging Clients with Substance Use Disorders, which is a pure chemical addiction guideline. And in our travels and in our work, we're noticing that Suboxone is becoming a lot more prevalent in Ontario, and that we have not experienced or heard of methadone being shortage. So yeah, but if you flag the question, we will definitely look back into that and see if we can get more support or evidence for that.
Great, thank you. I'm going to end with one last question to wrap up before we conclude. But a couple of questions have come in regarding monitoring. And one of them is, you've alluded to the use of methadone not only for addiction, but also as a method of chronic pain control. We find methadone useful in our pain practice. Do you include a standard of EKG monitoring to monitor for potential QTC prolongation and to also monitor for any other medications that could potentiate the prolongation?
Yes, we do. In our program, we actually, well, we tried. Ours was both pain control, was both chronic pain and addiction problems. And we baselined our EKGs. Everybody was supposed to have a baseline EKG, but we didn't do them on site. And what happened was that people didn't always go to get them. And we did not withhold methadone for addiction purposes if they didn't get it, but we got them whenever we possibly could. So as far as I'm concerned, it's part and parcel of the policy that should be in place.
And Deborah, I also want to mention that the RNAO recently is revising their pain best practice guideline. We're currently almost in the final stages of that. So for the individual who did ask that question, there will be a new best practice guideline coming out on the management of pain. So it's something to look forward to on our website as well.
Great, great. Well, let me just conclude with one kind of final question statement, feedback. This is a person who's a nurse in addictions nursing, has been in that field for 20 years, is at the Veterans Affairs Medical Center in Bronx, and in their OTP they use both methadone and office-based treatment. And the comment is, this was very informative and great to hear from our colleagues in Canada. So I just want to reiterate that and thank both of you for your time and coming onto this webinar to present the Canadian experience and for providing all of the wonderful resources that you have.
Thank you very much for having us and for all of you people staying around to listen to us. There's 115 or 16 people out there yet. So,
Great.
Oh, that's wonderful. Thank you so much for that comment.
So our time is up, and I want to thank you all for participating in this webinar. Shortly, you'll receive an email from the American Academy of Addiction Psychiatry that includes a link to an evaluation survey. We would ask you to take a few minutes to access it and provide your feedback on today's session. The webinar today was recorded and will be posted on the website of the Clinical Support System Opioid Therapies in the near future. The website is www.pcss-o.org. A calendar of upcoming events and helpful clinical resources are available there as well. And all of this information, including the handouts from today's program, and then the response to questions that Sabrina and Margaret have agreed to provide, will be posted on the INSA website at www.intnsa.org as well. And we do hope that you'll join us for upcoming PCSSO sessions. So keep watching the website and your email boxes. Thank you very much.